of the other teachers did them that teach this too. Cardiac testing, do y'all see that right there? That's what we're going to cover this morning. And that is a bulk of where your test questions, a lot of them are coming from. And that's near and dear to me because every day you go to clinical, you're going to send a patient many times for some sort of cardiac testing. Remember, cardiac's the #1 killer of everybody, women, men, everybody. So I think it's real important that you get a good handle on this because you yourself have probably had some of these tests anyway. Or if you hadn't, you will. You sound going to get it. You will. And that way it'll benefit you personally too. So this cardiac testing is a PDF on purpose because we were told by administration not to give you too much stuff. But we couldn't give you a study guide either. So I had to find my way to help you. They ain't said nothing about no PDF. So that's a way that I've tried to get around things to help you. So please don't complain, or they'll tell me I can't do that either. So that one would truly benefit you to study. It's cardiac testing. Do you see it? Don't say I didn't tell you. The concept of perfusion level 3 classroom, this is what the other cardiac instructors are using to teach this. And we've all agreed to use exactly the same stuff. Now, there will be some slides that I go, you can read that on your own. But you got everything they got. But the reason I choose to do that is because I don't feel like it's something that I want to use. Okay? But you might benefit from reading it, so read it if you want to. If I skip it, read it. Atrial fib video is a really cool video of a patient in atrial fib. It kind of helps you to get a picture of a patient and the concept that's going on in atrial fib and how they're going to treat it sometimes. So I put it there because I know your clinical experiences are going to be varied according to where you go. And no matter where you go, what kind of patients you're going to come in contact with. And so because of that, I put that there. Any video I put out for you is not going to be extremely long because I don't have any patience for it. And I get it. So if I don't show that in class, please take time and look at that because I feel like it will benefit you, okay? This level 3 cardiac posters is kind of funny. Over the summer, I was like, what is the beef of the disorders or diseases that they need to know in level 3? And I used to make posters in the room, not make you do posters, but we did posters together to put the main concepts down. But it took too long. So I kind of just made a PowerPoint of nothing but main points that you have to know. It's not a study guide, but it's kind of really will help you to make sure you have studied what you need to study. All right? So do your best when we get finished with this content to go through those to make sure you get what's on there. And if there's something you don't understand, come ask me. Y'all cool with that? And the reason I did that is because in level 2, we learned a lot of it. But I know if your brain's like mine, you've done stuff so much in there, something probably fell out. And the other problem I have in level 3 is and it's not a problem, I shouldn't have said it like that. The challenge is I have LPNs coming in, and I'm not so sure what you got. Does that make sense? And so I just kind of did this to make sure that you're on the same playing field as everyone. So it'll benefit everyone in this room to look at those as you cover information. Let's say you choose tonight to go home and cover MI, myocardial infarction. Then go scroll through this PowerPoint and find everything on MI and look at it and make sure you got it. That cool? All right, so I'm just trying to tell you the mission to my madness and stuff that I've developed after talking to LPNs or people who were asking me questions. I'm like, what could I have done to prevent them from missing this? And so that's one of the things that has been done. The other thing that causes a lot of grief for students in cardiac is there are different lab norms everywhere you look. In Iggy, in Pagana, which is the lab book, and everywhere where you work. So what I've done is made a PowerPoint of nothing but labs to help you at clinical, and also primarily if there's any lab on the test I give you, it will be based on that PowerPoint. Okay? So I don't want you struggling to find your norms. All right? Is that fair?
Yes.
Very fair. Okay. Then there's one that says cardiac biomarkers. And that one I will use as a reference to show you how these are detected in the bloodstream at different times. And that is why many facilities still will draw a panel instead of just one cardiac enzyme. And the reason that certain labs or cardiac enzymes are better than others, according to how fast the patient presented when their symptoms started. Most people, if they start having chest discomfort, what do they think it is? No. Gas. We want to think the best, because to me it's terrifying to think I have to go to the hospital. Not that I'm going to die, but I'm going to have to go to the hospital. And one of the reasons is my whole life I never had insurance. And so the thought of going there growing up was like, oh my God, I can't go there. And so that's frightening. And I am not very different than a lot of you in this room or people in general. And so they wait. They wait. And if they wait too long, then they may die before they get there, right? But there are people who have a horrible history in their family like mine, and I use my brother all the time, don't tell him. And when he first started becoming a man and understanding that he was at risk for disease, and he would get gas and want to go to the emergency room, and he did all the time, because everybody in my family that was male dropped dead very young of heart attacks. And so there's not many of us left, and he feels like the target's on his back all the time. And so I would laugh and go, please don't go there again. And so he don't do it as much anymore. But when a patient presents extremely quickly after having symptoms, a lot of times these enzymes have not had time to be detected in the bloodstream. So it's important that you understand that as a healthcare provider, because there'll be people with very strong personalities and they'll say, why are you keeping me here? If my lab is negative, I'm fine. Because see, they learn stuff on the internet and not always reputable sites. And it tells them, some of these sites will say, if your cardiac enzymes are negative, you're clear, you don't have heart damage. And so people get a hold of that kind of information, partial information, and some of them will show their butt and leave. And they truly are having a heart attack. It's just they presented early, they left, and those enzymes had not made it in the bloodstream where they were detectable. Does that make sense? So that sheet that says cardiac biomarkers, what it does is it explains when each of those labs are able to be detected in the bloodstream, when those enzymes will peak, the timing. Each one of them are just a little bit different, and how long they're going to stay elevated in the blood. So it's kind of a cool thing. It's not something you're going to have to memorize. Did y'all hear me? Mm-hmm. If you get the concept of that, you'll be fine. And so we're going to work with that. So don't think you have to memorize that page. That page is meant to explain to you what I just explained to you, that some things are detected very quickly in the bloodstream and some things are not. And I'll explain why we use each of those. Now, there's also a myocarditis. Y'all see myocarditis information _ Smeltzer? Mm-hmm. Oh. Iggy decided to take myocarditis out of your book. And I don't know why she did that. Typically, she is on the cutting edge of what is on your boards. So we follow her, but I still see patients in the hospital every day who have myocarditis. So you really do need to know what that is. So just take a moment to kind of review that. I got it from another textbook and scanned it there for you. It is on your objectives, and it is good information, all right? That's why that's there, and that's why it's coming from another book. I think that's good for you to understand. Do you see where it says additional supplemental sepsis videos right underneath that? Sepsis seems to be one of the hardest things for students and nurses to understand. I'm not sure why, but we miss it all the time. We miss it. And it's a huge initiative in acute care facilities right now. Just like heart failure, the disease, was one of the number one reasons that patients were being readmitted to hospitals, it was causing Medicare so much money for readmissions, it wasn't even funny. So they sent out a national initiative to say you're going to have to start implementing in your hospital, if you get Medicare funding, you're going to have to start implementing the gold standard treatment. And so you'll see hospitals have their own care paths of what they do for a heart failure patient, right? And we have to meet it 100% of the time. Well, now they're doing that for sepsis. And the reason is because so many people are dying. And they are dying in hospitals with sepsis. And because of sepsis, of all things. It gives me chills when I say that, because even to this date, this current time, we are catching patients in hospitals. It's missed. Me as an instructor and you as a student are catching it. And we are having to go up to the nurse and say, hey, he's got some signs of systemic inflammatory response. These are signs and symptoms leading up to sepsis. And we need the doctor to be notified. And they're looking at us like, oh. And so it's real important to me that you care to learn this stuff, and that you are that nurse that can pick up on that kind of information and help somebody. Because when I tell you the mortality rate when someone gets true sepsis and we miss it is like 80%. And I have horrible chills right now because it hits close to home. My daughter was raised in a community, and she went to a music school, and this music school had family, daughters, and one of their daughters was in her 30s and died of sepsis at Ocean Springs Hospital. That made me sick. So how does a healthy 30-year-old die of sepsis? And we're going to talk about that. And how did we miss it, or someone missed it? And so when you think, well, this won't ever happen to me, don't be fooled. Because it can happen to you.
You gotta know.
That was very important. I'm sorry. Somebody passed their boards. Just saying. Woo! Makes me excited. Is the reason I teach, and it makes my husband really mad when I get all excited. He goes, you don't get all that excited over anything else. Anyway, all right. Sorry. I was waiting to hear that, and so I'm relaxed now. Certain people tell me, they're like, pray for me. My results should be in about 2 days. And I've been praying, let me tell you. So, all right, thank you. Under where it says additional supplemental sepsis videos, I found these videos, and I loved how they were done. And this person teaches kind of like I teach, and he reminds me of my brother, and it makes it even funnier for me when I watch it. And if you can stand, you don't have to look at him when he's talking. He's real. And but anyway, he gives very good information on sepsis and helps you to understand it. And some of y'all are auditory, and some of you are visual, and some of you like to read a book, and some of you don't. And so sometimes if you can at least listen to someone talking about it, they may say it a little differently, and they're saying the same thing I am, and you'll go, oh God, I get it. So these are a little longer than I like, but not too long. So if you get a moment, they will benefit you and help you, okay? All right, that's why they're there. If you don't do them, you'll probably survive, but you'll be better if you do. Do you see the sepsis article? It's just a little article to make y'all understand what I'm talking about is current, and that it is well researched. And so I just want to make sure y'all know that kind of stuff. Because to me, I'm an adult, you're an adult, and I learn best when I understand the reason I'm learning it. The other thing, it says voiceover supplements. Do y'all see that? Mm-hmm. These are old voiceovers, and I know that there will be things that happen that you have to miss part of lecture sometimes, or that you tuned out during lecture because you're sick of hearing Miss Cooper talk. So what I've done is I've put the old voiceovers up in the event you're struggling with something that we cover in here, so that you have something to fall back on if you miss lecture or if you're just not getting it. Is that fair? Yes. Now, they may have some old page numbers or something, so you're just going to have to ignore that, but I felt like if I was a student, I would appreciate that. So I left all that there. Do you have to look at all that to understand all that? No. What I'm going to currently use is cardiac testing thing that I'm going to go over with you, and the classroom PowerPoint. I'm going to use it anyway because that's what everybody else is using. But I'm going to teach it my way. Okay? Everybody all right? Mm-hmm. Okay, the next thing that I think is real important for us to look at is your objectives. Have you looked at them? The reason I want to do this is because most people don't realize how many meds you've got to learn. Have y'all looked at that? Let's look at that. And let's talk about the meds to see what you remember. Let's see what you remember from level 2 or your LPN program. All right? And so this is your commercial. Just a second. This is your commercial. And we were told, this is so funny, y'all love this. Section 2 says they're going on break 10 till, and that we go on break at the top of the hour. If you got pee problems, we'll go at 30 minutes if you want to, but we can't go at 10 till. Okay? They don't want to pee when we're peeing. Okay. No, they're trying to be nice, I guess. It's the right thing to do. We can't think negative now. We got to change it around. Don't get Miss Cooper on her main street now. She's in trouble. All right. I'm going to skip down. I'm not trying to make you crazy, but I want you to look at these meds. All right, it starts at F. Organic nitrates. What does that mean? Nitroglycerin. Nitroglycerin. This is in your syllabus, and it's your objectives for cardiac for level 3 in your syllabus, NUR 2318. And what do you know about nitro? Take 3. Good. Take 3 if it's under your tongue.
Call after you take the second one.
Call 911 before you take the second one.
Every 5 minutes.
5 minutes. That's good. Every 5 minutes. Every 5 minutes. Needs to be in a dark, airtight container. We have to replace them every 3 to 5 months. Awesome.
You leave them in the container, they come in.
Amen to that. Leave them in the container, they come in. What else?
Don't keep them like in your pocket.
Don't put them in your bra or your pocket. Good.
Don't get it in your eye.
No. You remember that, don't you? Yeah. Yeah. And now Y'all get nothing mean. Okay, what about giving nitroglycerin tabs in the hospital?
You need to make sure they're not.
You gotta check their blood pressure and their pulse.
Thank you. Okay, it's bizarre. You know, we give these people, here's your nitro, take it home, good luck. You know, and they don't take their blood pressure before they stick that under their tongue. But when we're at the hospital, we are held to a skilled RN level. And the skilled RN needs to understand that it's unsafe
Nitro drops your blood pressure.
to give nitroglycerin to anyone without knowing their blood pressure first. Because if their systolic blood pressure is less than 100, you need to let somebody know. Your book may say 90, but we're going to go with 100 for your test so it won't stretch you out. Okay? So why do you think that is? And I think I heard Kelsey tell somebody.
It drops
It
your
drops
blood pressure.
And why does it drop your blood pressure?
Because it's a vasodilator.
So it's a vasodilator, and it actually makes all the vessels larger. So it makes, I call a vessel system the tank. So it makes like your tank larger. So if you make it larger, it drops the blood pressure that's running through your vessels lower. And now we're going to learn some words. We already started learning some words in level 2. Do y'all remember the word afterload? And afterload is the resistance that the heart has to pump against. And what is the heart pumping out into? The arteries, the vessel system, right? So if you give someone nitroglycerin and it makes all the vessels expand and makes them larger, it makes the tank larger. And what does it do to afterload? Decreases it. And so in your pharmacology books, it'll say nitroglycerin decreases preload and afterload. Afterload, we said, is the resistance that the heart has to push out against. And it should make you understand that nitroglycerin makes the heart's work so much easier because it does that. Because if my heart is stressed, and I'm having chest pain because my heart muscle itself is not getting the blood it needs, then my heart, I don't need to be making it work harder to push out, do I? So if we can give something that is going to open all the vessels, not just the coronary arteries, because it's going to work on the coronary arteries too. We want to do that, but we also want to widen out the vessels coming off the heart so that when the heart pushes, it don't have to push so hard. Does that make sense? Okay, so we're talking about nitroglycerin. So we are talking about giving nitroglycerin under the tongue. That's what y'all are most familiar with, right? Now there are other ways we give nitroglycerin. What are they?
Paste and spray.
Paste and spray. The paste is what the doctor order how long he wants the paste to be placed on the little thing that looks like wax paper that they put on the patient's chest. That's very fast acting. What's the number one complaint that the patient's going to say? Because it is dilating vessels, and it also it doesn't pick which vessels it dilates. So it's going to dilate vessels in the head and cause headache. So again, what we do as good nurses, some of us, is we'll take it off the chest and stick it down here. I laughed. I went in one night, and the man had complained so much it was on his foot. I was like, now how helpful is that? But anyway, I get it. So we understand with the paste, you got to make sure you got gloves on. Because if you get that on you anywhere, it's going to start acting on you. And if you touch your eye like Miss Cooper did one time, it will blow your pupil, and then you'll think you're having a stroke. But anyway, so make sure you always wear your gloves. So that's safety with nitro paste, or really even touching it. The pills, the tablets. Y'all be careful with that. Now, paste is fast acting, but they also come in patches that are long acting nitro patches that deliver it just a little bit over time, but it's still the same thing doing the same thing. The spray is the spray they do under the tongue. You don't see that as much. Most people prefer the tablets. Sometimes people have dry mouth or they have diseases that cause them not to have any spit, so they will do the spray. You can also do like a teaspoon of water if it's a little old person and they don't have, they're really dry, and sometimes we see that. And like we put it under their tongue and it won't go nowhere. It's like still perfectly there, it hadn't dissolved. You're like, oh Lord. So you just get a little teaspoon of water and put it under there and help it to dissolve. That is fine.
With the headache as the number one complaint, is that just with nitro in general?
Nitro in general.
Okay.
Nitro in general, very common. The other thing I want to make sure you know is we give nitro orally as well, and it's long acting, and it's called Endure. You've probably given it and haven't really even thought about it. But it is an oral nitroglycerin that many cardiac patients take. It cannot be crushed. If you crush it and give it, I've seen it. I've witnessed it. The patient goes completely white, whether they were white or not, and they will profusely sweat. It's terrible. You drop their blood pressure to nothing. So, not good. So make sure you know not to crush anything that's long acting. And if you have any questions, don't trust the nurses around you. We were at clinical last semester, and somebody said, I just happened to be at the desk, and somebody said, can you crush such and such? And yeah, I think I crushed it 2 days ago when I had that patient. I was like, no. Look it up. Look it up. And the nurse went, crush that. I was like, well, don't make her feel bad, but you better tell her, but tell her in private. Anyway, so don't trust that.
What did you say the oral was called?
Endure.
Endure?
That's probably the trade name. But there are many trade names for things. But I think you need to understand, the point I'm trying to make, you don't have to know everything, is that they give nitroglycerin in many forms, okay? And some of them are long-acting forms. We were talking about the tablets under the tongue, so are those fast-acting? Yes, which means they're not going to last for a long duration. Anything short-acting is going to get in and work, but it's going to stop working pretty quickly. Does that make sense? Okay, the other form of nitroglycerin we're going to hit hard in level 4 is IV, intravenous. And if you're given intravenous nitroglycerin, the patient needs to be in the ICU. It has a protective sleeve around it to protect it from the light. So again, that's an easy concept to remember about nitroglycerin, is that it needs to be protected from the light, whether it's IV, whether it's a tablet. So that's an easy way just to remember nitroglycerin. And the thing about nitroglycerin, it drops blood pressure. So if their blood pressure is low, we're going to question giving it before we give it, and the doctor's going to make that decision. And we have actually given it when their blood pressure was low after the doctor told us to, because then he told us go ahead and hang a fluid bolus. So we're just going to try to manage the blood pressure and the chest pain all at the same time. But on your test, we're not doing that. Okay? Does that make sense? So we've talked about nitroglycerin. What have you learned so far? Okay, so this is your commercial. This is how you should know your medicines to safely give them. Now, what else about nitroglycerin is a huge safety concern?
Wear gloves.
Thank you, Raina. If the patient, and you need to ask a couple of different ways. Are you taking any medications such as Levitra, Cialis, Viagra? Revatio is how they renamed it for women. It was designed for women for pulmonary treatment of pulmonary hypertension, and they didn't want to take it because when they come into the hospital it said Viagra, and everybody's snickering, she's on Viagra. But it's not for that. It's for pulmonary hypertension in women. And so they went ahead and changed the name of it for women so that it wouldn't be like such a stigma. And that's not, we shouldn't be that way, but I guess that's just human nature. And what happens if you give nitroglycerin and they didn't tell you they took it 24 to 48 hours ago, is it can cause the blood pressure to drop, and we just about can't get it up. I mean, that's kind of funny that I said it like that, but, it just come out like that, not intentional. And they end up in the ICU on all kind of drips, and it's just a really bad scene. And so we can prevent that if we know to ask that question. Make sense?
Yeah.
All right, so we learned a lot about nitro. Talk to me about beta blockers. Ended LOL, all of them do. We taught yesterday, it's very important safety that you check a couple of things before you go give it. What are they? Heart rate. We want it to be, your book says above 55. We've been going with 60 on your test, just so you don't stress out. But in the real world, you're in the real world. Well, I've been taking medicine today, but typically my heart rate is 53. I take beta blockers, and that's why it's that 53. And I take it again, even though my pulse is 53. And I'm fine. However, if you go to give a beta blocker in the hospital and your patient's heart rate is 53, what is their norm?
You gotta look at it.
And how do they look? How do they feel? If they're telling you, I feel so bad, like I can't hardly sit up. And you think perfusion might be a problem if they're telling you they're weak and they feel bad? Yes. Because if your cardiac output, what's cardiac output mean?
Their perfusion, like their blood pumping through their body.
Thank you. It means the amount of blood coming out of their heart. How much blood is their heart pumping out, their cardiac output? When we give beta blockers, we're slowing down the heart rate. We're slowing everything down, and we're doing it for a reason. If it's given for cardiac purposes, if the beta blocker is given for cardiac purposes, it prolongs diastole. I know y'all don't throw nothing at me. But diastole is the resting period, do y'all remember that, of the heart, and that is when the heart muscle itself is getting its own blood supply.
The one back
So, and the coronary arteries are getting fed. So, in the cardiac patient, the beta blockers really help for the heart to get good blood supply because it slows down and prolongs diastole. So in that case, it's okay as long as the heart rate is not too slow because of the concept of what cardiac output is. The equation for cardiac output, don't think equation, oh God, she just turned me off. Cardiac output is heart rate times stroke volume, which all that means is, you know what heart rate means. Stroke volume is just the amount of blood pumped out of the left ventricle with each beat. So heart rate is a big determinant. It is a big piece of cardiac output. If the heart rate is extremely slow, is enough blood coming out? What do you think their cardiac output is going to be? Low. If it's really high, all right, tell me about diastole. Is the heart getting fed? How much blood's going out to the body? Does it have time to fill?
No.
Okay, so do you understand that when you look in the book, it'll say cardiac output equals heart rate times stroke volume. And so the extremes of heart rate either way is going to make cardiac output do what? Go down. So you're understanding that, right? So this semester, let me put it all together for you. This semester, you have to learn what normal cardiac output is. Ready? I'm going to tell you. Normal cardiac output is 4 to 7 liters per minute. 4 to 7 liters per minute. So let's take it a step further like a nurse. Because I was like, well, why do I need to know that? That's stupid. I'm sorry, I'm just being honest. Well, if you go work in the ICU, we have these really cool little lines we can stick in you. They're called Swan-Ganz catheters, and we're going to talk of pulmonary artery catheters. We're going to talk about that next semester. And we can dip that little catheter in you, and it'll tell us exactly what your cardiac output is. It is super. But now let me tell you what that should tell you as a nurse. If I told you that normal is 4 to 7, right? If I told you a patient's cardiac output was 2 or 2.5, is there a lot of blood coming out?
No.
What do you think their blood pressure is? Low. So if I told you a person's cardiac output was like 4 or 5, you would expect their blood pressure would be normal. And if I told you, it'd be about 120 over something, 130 over something, that's pretty normal, right? So do you see how as a nurse you have to take this information and be able to apply it? And so that's what's important to me. And so there's something on your objectives up here that says hemodynamics. And the hemodynamics that you're going to have to learn on your objectives are cardiac output, which, what did we just say that was?
47 liters per minute.
You got to know that, okay? And you also have to know that if it's low, their blood pressure is going to be low. And if it's on the high end, I bet their blood pressure is going to be a little higher, okay? Now, I was just using that as an example. So let's take that example just one step further to see if you're understanding this. So if someone's cardiac output is 2.5, then what are some assessment findings which you might correlate with that? Tired. Are they going to be thinking good? Do you think they're perfusing their brain really good? Might they be a little confused, disoriented, or agitated? Something weird going on with their LOC because their brain ain't getting enough blood? What do you think about? What about their? Or you think their heart? They might have a little chest pain, maybe.
Yeah.
Because if you think their heart's getting the blood supply it needs, maybe not. What else? What about their O2? Their O2 sat might be a little low, but more so, will they be perfusing out to their extremities? No. Because if your cardiac output falls low, what does your body do to compensate?
Suck it everything
It
in.
pulls everything towards your major organs, right? Now, if your cardiac output is really low, what do you think the perfusion to your kidneys is? So what would you be watching for?
I know.
Okay, you'd be watching for urine output. And how much should someone have? At least, you got to know that. So it would be easy on a test to give you a cardiac output and ask you what assessment findings correlate with this output. Right? So some easy ones would be blood pressure, urine output. You working with me here? So this is how in level 3 and 4 you got to start thinking. These questions now are application. You get lucky, I'll throw you a comprehension every once in a while. But primarily they're application. So I'm not going to ask you what normal cardiac output is. Right? You understand it? Okay. All right. Beta blockers. We didn't hit all the highs on the beta blockers. So we talked about blood pressure and pulse. What else about a beta blocker you need to know? Do they vasodilate? No, beta blockers. How do beta blockers work? Huh? They're going to lower your blood pressure, but they're beta blockers. So they work on the sympathetic nervous system. Do y'all remember that? Like, no, Miss Cooper, don't go there. sympathetic nervous system. Y'all remember the autonomic nervous system from A&P? There's two divisions of the autonomic nervous system. Sympathetic, parasympathetic. It's coming back to y'all now. I get it.
That's the one that slows that SA nerve down?
Yes, you're getting there. I love you. Okay. Y'all ready? Sympathetic nervous system is your fight or flight. Y'all remember that one? And your chemical mediator for that is called, my mama says adrenaline. Your adrenaline kicks in. You can kick her butt. Your adrenaline kicked in. I'm like, Mom. No. So adrenaline, the other name for adrenaline is epinephrine and norepinephrine. That's the natural adrenaline that is in your body that is released when your sympathetic nervous system is stimulated. Like if I told you, oh, I forgot y'all got your test today. Wouldn't y'all go, oh, Miss Cooper? And your heart would race. Do you know what's causing your heart to race? Your adrenaline. Your natural sympathetic nervous system response. You have natural epinephrine and norepinephrine in your body that comes out when your sympathetic nervous system is stimulated. So what stimulates your sympathetic nervous system? Fear, pain, right? Any stress on your body. And so beta blockers work on the sympathetic nervous system by blocking all of that. The problem comes, the first beta blockers that were put on the market were things like propranolol, otherwise known as Inderal. It is what I take, and it acts everywhere in my body, okay? And the reason I take it, just FYI, is migraines and a tremor. And I stay, like, I'm ready. I hit the floor and I drive my husband crazy. Let's go. And I'm like that all the time. And it's not good. And I would never carry a gun because I will shoot before I ask you any questions. And that's my personality. So I know not to do that. And so again, I benefited, and that's why the tremor is I had a constant stimulated sympathetic nervous system. So the doctor gives me that, but before he gave it to me, he said, are you diabetic? We have to be cautious with diabetics taking non-cardioselective beta blockers because if you mask all of the responses of the sympathetic nervous system, your sympathetic nervous system can save you if you're diabetic. Because what happens if your blood sugar drops? You get shaky. You're supposed to get shaky, headache, fussy. So it's your body's warning system. So diabetics should not take non-cardioselective beta blockers, the ones that were first put on the market. But if you're like me and I'm not diabetic, but I need something to block all this stimulation, is perfect. It also helped prevent me from getting migraine headaches. I don't get migraine headaches anymore, which is a blessing, right? Okay, now, so we just said, I gave you some information about diabetics and non-cardioselective beta blockers, didn't I? Now, there's another problem with beta blocking, because if you block all your beta receptors, how do some of your puffers work? For respiratory, you're going to find that they help to, when you do a puffer and you have asthma, what does that puffer do? It relaxes the smooth muscle, right? All that tightness, it relaxes it so air can come in, opens you up, right? The puffer. Well, if you've got somebody who's asthmatic and you give propranolol to them, you've messed up because you blocked the action of their puffers. So again, because the farm people, I call them the farm people, these people who make all these drugs were like, oh, we got to fix this. So the scientists got together and they developed beta blockers that only work on the heart, such as carvedilol, which is the other name is Coreg. And so again, you need to watch in the hospital when you're given beta blockers because some are cardioselective, which are fabulous. And then the old ones are they're not cardioselective, so they work everywhere in the body. Okay? So if they are not cardioselective, you have to worry about diabetes and asthma. Diabetes and asthma. So again, I try to tell you these things so you'll remember it.
So it's not cardio-selective, you gotta worry about diabetes and asthma.
If it is right, that's correct. Because if it's cardioselective, it only works on the heart. So it's fine to give diabetics and asthmatics. Because they had to develop something. Yay! So I am not gonna give you a question to fool you like that. Okay? I don't expect you to know which beta blockers. Did y'all hear me? Yes. I don't expect you to know which ones are cardioselective and which ones are not. So I knew that was coming. Just relax. But I think it's important because when you look up beta blockers, I get this question every semester. They'll go, Miss Cooper, I don't know which ones are which. And oh my God, do you know how many are out there? And then they'll look up the med and they'll go, did you know they give beta blockers to people with migraines? Did you know they give beta blockers for I'm like, yeah, I take you for that. But I go ahead and put all that out there so that when you're studying, you won't be freaking out. All right? Because there's a lot of information out there, right? Okay. All right, so they go on break first. They're having their pee break. Don't get jealous. How, y'all good with beta blockers so far? Have you learned anything? Yeah. Good commercial? Yeah. Okay. Just a little bit more, and we'll go pee. Right behind them. Push them out of the bathroom. All right, better hurry. Calcium channel blockers. Tell me what they do. If you tell me they block calcium channels, I'm gonna. What do they give them for primarily? Huh?
Force of contraction, decrease the.
Listen, Stephanie's over here working it, y'all better. She's the only one over here working it and trying it. Primarily, they're going to give it to patients who are having angina. It's going to slow conduction. So what does it do in the heart rate? Just a little bit. Slowing it down a little bit. And with calcium channel blockers, do we have to worry about blood pressure? Yeah? Do they give some calcium channel blockers for hypertension? Yes. So, do you need to know calcium channel blockers? Yeah. All right. So, on our next commercial, I'm going to ask you the name of some calcium channel blockers. No! Like you. Like your tongue. It's just too many. I know. All right, hold that thought. We're going to talk about them on our next one. Y'all about had all you can take for one sitting. When you look at I up here, y'all see it says pharmacology, renin, angiotensin, aldosterone system. Oh God, give me a chest pain. Let's talk about ACE inhibitors here. Let's talk about, what do ACE inhibitors end in? Priel. Let's talk about, this is just for Kelsey from yesterday. Let's talk about ARBs, ARBs. They end in the drugstore name. Sartan. So put that one up there. You can look up the other ones. Do y'all know what aldosterone antagonist? Do y'all know what that is? Y'all know what that is? Potassium sparing diuretics. Yeah. What's the main one we use? Spironolactone. Yeah. But I want you to primarily focus on what? ACE.
ACE and ARBs.
And ARBs. ACE end in Priel. ARBs end in Sartans. Okay. Don't go crazy. And then, if I told you the drug under the J thrombolytics is something that we kill people with, not meaning to. Do you think that would be a good one you gotta learn? If NCLEX tests safety, do you think that one is a big one? I promise you'll see questions on thrombolytics. And so we'll talk about those too when we have our next commercial break. Do y'all know foods high in iron?
Spinach.
Meats. Okay, make sure you know about iron. That'll be on your NCLEX, I assure you. We'll talk about B12, folic acid, and why the B vitamins are important. I think that's just good knowledge. Is that something I'm gonna test you on?
No.
Probably not. Probably not. But I want you to understand the role. The role of the B vitamins and folic acid is it helps to prevent buildup of things like homocysteine in your blood. And homocysteine in your blood, I'll show you on your lab when you come back from peeing, is a risk factor for cardiovascular disease and stroke. So we'll talk about that when you come back. So it's our turn. It's 10 o'clock. Go push my back. Not be nice.
For the B12 and folic acid. Hold on.